Hello, this is Annette Rebel from the University of Kentucky, and this presentation will review the principles of neuroanesthesia. For this presentation, I will assume that you have reviewed the videocast on neuroanatomy, neurophysiology, neuromonitoring. So this presentation can focus on the core essentials of neuroanesthesia, the anesthetic goals, the pharmacology, and then also comment on the specifics of several surgical procedural types. So what makes patients in the neurosurgical operating room special? They either have or are at risk for intracranial hypertension. They have neurological disease, neurological abnormalities in form of brain edema, mass lesions. They also, you need to be aware of what kind of position we will perform a surgical procedure, because surely some positions have implications for anesthetic management. And if a patient has suffered a head trauma, also we have to know how to prevent the secondary brain injury during the surgical procedure. So intracranial hypertension, as we already have reviewed that during our neurophysiology lecture, the brain is captured in a rigid compartment, meaning the cranial vault. So therefore, if the brain is swelling, other areas have to give. So as the brain volume increases due to swelling, edema, then other compartments, first the CSF, then cerebral blood volume, has to give. The Monroe-Kelly doctrine indicates in this graph kind of like that in the beginning, as your cranial volume, your brain volume increases, okay, your ICP really doesn't change much due to the squeezing out of CSF, and then as we are further increasing with our volume increase, and that's when the ICP starts, and also then your cerebral perfusion will suffer due to increased intracranial pressure. We call intracranial hypertension a sustained ICP increase if above 50 mmHg for a prolonged period of time. If ICP stays above 30, we can assume that cerebral blood flow, cerebral circulation is decreased. Something you may or may not have observed in the past, like the Cushing response, if cerebral circulation and perfusion is compromised due to increased intracranial pressure, there will be a sympathetic response causing periodic severe hypertension with bradycardia as an autoregulatory response to your cerebral blood flow compromise. The brain is asking for more perfusion, therefore increasing your blood pressure, and the bradycardia is a reflex response towards that. So what can cause increased intracranial pressure? Most commonly, cerebral edema, which can be cytotoxic, vasogenic, or interstitial, but the brain swelling, so therefore increasing your intracranial pressure. You also, if you have an increased cerebral blood volume, as it would be during compromised venous drainage, mechanical versus thrombotic, or due to hypercapnia, acidosis, hypoxia, loss of autoregulation, as it would be during a hypertensive crisis, or it can be due to an obstruction of your CSF flow as an obstructive or occlusive hydrocephalus, or if absorption is compromised in a setting of increased production, as it would with meningitis, or space-occupying lesion, and then a more regional, not a more systemic problem. Patients with increased intracranial pressure have following symptoms: headache, nausea, vomiting, acute mental status changes, focal neurological deficits, postural seizuring, most commonly seen as a CNS symptom of increased ICP. Respiratory status from hyperventilation, trying to keep your PaCO2 low, or change stroke patterns, signs of respiratory distress, also can be a sign of increased intracranial pressure. Pupil response may be unequal, unreactive, sluggish to light. If you do a more detailed eye exam, papillary edema. The Cushing triad, which indicates impending herniation, is a combination of hypertension, bradycardia, the previous mentioned Cushing response, in combination with abnormal respiration. So how do we approach patients in the neurosurgical arena? Part of the preoperative assessment is to identify patients at risk, either at risk for increased intracranial pressure or already pre-existing increased intracranial pressure. Review all the pre-medications. Are they on steroids? Dexamethasone has been used to decrease the edema associated with space-occupying lesion. Are they on anti-epileptics? And obviously sedation, and therefore changes in PaCO2 can very rapidly change your intracranial pressure depending on where you are in the Monro-Kelly doctrine. Review the CT, the images. You want to know, based on CT, MRI, what lesion you're dealing with, what is the status of your cerebral edema. Identify space-occupying lesion not only through patient exam, but also through reviewing the chart. Keep in mind that electrolyte abnormalities are not unusual in those patients, either related to medications as dexamethasone, diuretics, anticonvulsant therapy may, or if it's related to a neurological disease, which is SIADH, cerebral salt wasting, and diabetes insipidus. So after completing the preoperative assessment and identifying our patients at risk, so how in the operating room, how do we treat them intraoperatively? The general anesthesia induction in a patient with increased ICP can be kind of tricky. You have to balance aspiration risk versus the need for deep and gentle anesthesia induction without hypercapnia, without barking, coughing, because all of this would increase your intracranial pressure. Also imagine a patient with a little bit more complex airway management, difficult intubation history. All these, can maybe counteractive to your anesthetic goals. It would be for a patient with increased intracranial pressure. So most commonly, what we do is we place an awake arterial line to have a continuous monitoring of perfusion pressure. Then we do an IV induction with propofol and fentanyl. Take over the ventilation as you paralyze, and you assist mask ventilation as you take over from the patient as the patient becomes more and more unconscious. You aim for modest hyperventilation. For sure, do not increase your PaCO2. After you gave your neuromuscular blocker, you will allow enough time for paralysis. Even you may have to redose your propofol. Again, you want your patient deep. Then you perform your direct laryngoscopy. In a perfect scenario, somebody would monitor the blood pressure while you're performing your direct laryngoscopy to avoid any blood pressure spikes. Monitor your mean arterial blood pressure closely during your DL and manage very closely around baseline. You don't want straining, coughing, or light anesthesia to increase ICP, but you also don't want hypotension. Have esmolol available to counteract if a patient has a sympathetic response to your direct laryngoscopy. An esmolol I usually give between 0.5 to 1 milligram per kilo as an IV bolus if a patient shows signs of hemodynamic response to your DL. So intraoperative, you maintain your cerebral perfusion pressure and your cerebral blood flow. optimize your hemostasis to minimize brain edema. What that means is like, okay, TIVA or total intravenous anesthesia is the probably most commonly used anesthetic technique for neurosurgery, because you want to avoid the volatile anesthetic related increase in cerebral blood flow. If you have to, you can use sevoflurane up to a half MAC to deepen when needed, but majority will be provided by propofol and remifentanil, since those medications have been shown provide deep enough anesthesia for those procedures, but also wander off without accumulation postoperatively. We talked about arterial blood pressure monitoring, and this is advantageous to do this before induction. Here, the PaCO2 and PaO2 management, you also want to keep this at steady state, and your transducer should be zeroed at brain level, so the perfusion pressure really reflects your cranial perfusion pressure. Thrive for normocapnia if a surgeon requests brain relaxation, mild hyperventilation, PaCO2 around 30. Temperature monitoring is important if possible. Foley or bladder temperature monitoring, since this represents most the core temperature. The IV fluid at maintenance, we prefer normal saline, since this is a intravenous fluid which is not hypoosmolaric and therefore may not contribute to the brain edema. Sodiums you want to keep at baseline or slightly hypernatremic, since it minimizes your brain edema. For sure, avoid hypoglycemia, but also avoid hyperglycemia. Worst case scenario for sure is a low glucose level, but even elevated glucose levels are associated with poor neurological outcome after focal and global cerebral ischemia. If a surgeon asks for brain relaxation, mannitol, muscle relaxation, head-up position, and then furosemide are utilized. If a patient gets hypertensive, consider bolus propofol to deepen the anesthetic, or esmolol, since that it does not cause vasodilation and therefore does not increase your ICP. If a patient is hypotensive, alpha 1 agonist, phenylephrine or norepinephrine have been used most commonly, or if you want to, for whatever reason, patient is not a candidate for alpha 1 agonist, then also you can consider vasopressin. For emergence, the caveats for neurosurgical patients to remember is the goal is a patient wakes up immediately after surgery, but a smooth emergence. So why do we want the patient to wake up? Well, that's really the best marker of brain function, is a brain working. So that's why a surgeon is going to be interested if that has not been compromised during the surgical approach. But any kind of agitation, hyper or hypoventilation, barking, coughing, changes ICP. So it really is the smooth landing, which is very important for this patient cohort. Any changes in PaCO2 should be done in a controlled and speed appropriate fashion. Avoid hypoventilation, avoid hyperventilation. If you utilized hyperventilation for brain relaxation, slowly and controlled reverse it to back normal. Allow the bicarb, which may have accumulated in the CSF, to slowly be actively transported out of CSF, so pH doesn't change, because the pH of the CSF is the one which really then transfers towards the vasodiameter and therefore ICP. Since the surgeon is working on the head, you may not have full access until the surgeon is done with that patient. So make sure the patient is out of those Mayfield pins, the really sharp head pins to keep the head in a certain surgical position. So don't reverse, don't use your neuromuscular blocker reversal until you have access to the patient. Obviously, it depends on patient position and if in male field or not. Dexmedetomidine has been very successfully utilized to facilitate smooth extubation after those procedures. For avoiding bucking, coughing, waking up slowly, facilitating pain control, and you still are going to be able with dexmedetomidine to have a patient following commands and to interact with you. Well, if you're in a room and pharmacologically your patient should be waking up but isn't, what if there's a delayed emergence and you really don't have a reasonable explanation based on pharmacology, electrolyte status, etc.? Be prepared to transport this patient to the CT scanner for imaging, because there may be a post-op bleed, there may be a brain structure compromised, which was a result of the surgical intervention, not your anesthetic technique. So always have this on your differential diagnosis and be prepared to do that. We mentioned positioning neurosurgery. So very important pre-operatively to have a discussion with your surgical colleague to explore what's the plan. As you can see in those pictures, there are a little bit more weird patient positions. You have to plan for: where are my IVs, where is my access, how am I going to pad, to keep my patient safe during the surgical procedure, and then also for if I need to get access, where is what. The posterior fossa craniotomy can be quite challenging for the anesthesia provider. It can be done prone versus sitting position. So the unique problems associated to that kind of surgical intervention is a posterior fossa. That's where your fourth ventricle goes through. So those patients for sure are at risk for an obstructive hydrocephalus. Even preoperatively, they may have an obstructive hydrocephalus, which you need to know before you induce anesthesia. If they're infratentorial masses, they can not only put pressure on the brainstem, but also, if you decrease ICP, actually may work against you, because then your infratentorial pressure actually pushes even further on brain structures like the brainstem. Posterior fossa craniotomy can cause a direct surgical injury to the brainstem, which may not be obvious until you emerge, or can intraoperatively cause significant cardiac arrhythmia from severe bradycardia to asystole. Sitting position approach to the posterior fossa, those patients surely are at risk for pneumocephalus and venous air embolism. And if in sitting position, that's why you need to know before you take this patient to the operating room, you may need additional monitoring. Not only central line, but also how you monitor for venous air. So all those things should not be a surprise to you when you bring a patient to the operating room and the surgical colleague discloses his plan. Pneumocephalus, common, but most of the times asymptomatic complication after open craniotomy. That means air has entered the subarachnoid space and replaces CSF. And can be in all areas of the brain, as you see in the CT scan. There's air here, but also here in the lateral horn, and also here in the third ventricle. Pneumocephalus not only causes significant headache in an awake patient, but post-anesthesia can cause or can be the cause of delayed emergence and of focal versus global neurological impairment and deficit. Obviously, cases like this, you should not be using nitrous oxide because of the replacement of oxygen, but yeah, the nitrous oxide will only increase the expansion of the pneumocephalus. The treatment of pneumocephalus is give a patient 100% oxygen, because that will be resorbed. Venous air embolism, also a feared complication in the neurosurgical patient collective. And it's more common when your surgical field is above heart level. So if your cerebral brains are above heart level, that can be a cause for venous embolism, because if there's a preload fluctuation, low preload, then it gets sucked in not only with opened of the cerebral veins, then air gets sucked in and enters systemic and enters the circulation. The air from the surgical field then will be trapped primarily in the pulmonary circulation. As you see in the CT scan, also marked with the arrow, there is air trapped in your pulmonary artery. So primarily trapped in the pulmonary circulation, and then can cause, like a PE type of picture, a lock of the circulation. If a patient has a patent foramen ovale, a PFO, and has a right to left shunt, that air can, this patient can develop a right to left shunt, as if the pulmonary circulation is occluded, increase in right side pressures, so then therefore non-pre-existent but then developing a right to left shunt, and then air can cross over and cause a paradoxical air embolism, that more clinically looks like strokes. Surprisingly small amounts of absorbed air, usually pretty well tolerated and asymptomatic. Large amounts can be lethal, as it can completely mechanically obstruct the pulmonary circulation. The monitoring for venous air embolism, how do I know air gets into the heart? TE probe, precordial Doppler, or a sudden decrease in end-tidal CO2 tension, with different monitoring techniques in the past, where we also could monitor nitrogen. If there was nitrogen showing up in the expired gas, you also knew that air has somehow entered your circulation. A patient who has a venous air embolism, what do we do? And this is really here, step by step. First, notify your surgeon. Houston, we're having a problem, because he can flood the surgical field, so therefore stops the air aspiration from those open veins. So that's what is step one. Stop the problem. Ventilate with FiO2 of 1 or 100% oxygen. And I hope you didn't use nitrous oxide, but you really should stop using it if you are suspicious a venous air embolism is going on. If you can, try to change the position, either right side up or head level. Get the veins below the heart level. So also that stops the aspiration. If you have a central venous line in place, aspirate. Currently, to support circulation, you want to give a fluid bolus, you want to maintain intravascular filling. If a patient is hypotensive, support your circulation by giving vasopressor. Most of those situations, you probably have to pull out the bigger guns. Ephedrine or phenylephrine may probably not be potent enough, and you probably want to consider also some better inotropic agent in that situation. So epi, norepi, in that situation is probably your best choice. If you have access to the neck, you can try to compress bilaterally the jugular veins, because it slows down how the air adds to the pulmonary circulation. If you can, if it's hemodynamically tolerated, PEEP increases the interthoracic pressure, so therefore supports pulmonary circulation, but it also may increase your right-sided pressure and therefore facilitate paradoxical air embolism. If a patient is hypotensive, unstable despite previous actions, head down and prepare for circulatory deterioration, and you want to get ready for advanced hemodynamic support, which means like call for help, call for the code card, get your epi, no-epi, everything you need to treat ACLS or to provide ACLS and treat circulatory deterioration in the patient in front of you. A very big electrolyte, an important electrolyte in the neurosurgical patients is sodium. And so why this is probably more review of neuro-ICU, let me just go quickly through here why we need to keep an eye on sodium and how it can help you. So wherever sodium is, that's where water will go. That's just basic of our body. So if your sodium level is low, then there will be more swelling. If your sodium level is high, you're concentrated, there is less water. Okay, so you want to avoid low sodium levels. You want to, if you treat cerebral edema, you want to err more on the higher sodium side. That's one reason, like to control your water homeostasis. Second reason also is sodium is an important electrolyte in the neuronal electrical activity. It's part of your action potential, right? So also sodium, especially fast and rapid sodium shifts, also affect neuronal activity. So you should avoid that. Okay, whenever you can, don't make rapid changes with sodium for water status, but also for seizure thresholds and neuronal activity. So the three pathologies related to sodium level we need to keep in mind in neurosurgical patients are diabetes insipidus, SIADH, and cerebral salt wasting. Diabetes insipidus is the one associated with pathologically high sodium levels. SIADH and cerebral salt wasting, these are the two circumstances associated with hyponatremia, low sodium levels. So let's talk first about the diabetes insipidus. Can be central versus nephrogenic. Central means there is no antidiuretic hormone or ADH, either because your hypothalamus, which produces it, got hurt, or the pituitary gland, the more posterior lobe, got hurt because that's where the ADH is released. Patients with diabetes insipidus, like the nephrogenic, you want to differentiate central from nephrogenic, because nephrogenic really, like here, it's not the ADH problem, it's more like that the kidney does not respond to the antidiuretic hormone. It's the inability of the kidney in the collecting tubular system to have that receptor for the ADH. The way how diabetes insipidus look like is like large amounts of very dilute urine. So therefore a patient not only loses electrolytes, but also severely dehydrates. The way how we diagnose it, it's a very low urine osmolarity. The urine is not concentrated, so the osmolarity in urine is lower than the plasma. That's the hallmark of DI. And the urine sodium concentration also is extremely low as a representation. It's non-concentrated. For the treatment approach, you need to know if it's central or nephrogenic. First of all, you will replace the water deficit. Then if it's a central DI, desmopressin, which is DDAVP, or ADH, either IV or nasal, will replace that hormone the patient doesn't have, and so therefore immediately reverses the large urine production. Vasopressin also is an analog to that, so also has a partial affinity towards this receptor, and so therefore can, not as impressive as desmopressin, but also has an effect there. Carbamazepine also has been described as a medication which can positively treat DI. The nephrogenic diabetes insipidus, because here it's not the ADH problem, it's more like the kidney not responding to it. Stop the underlying cause. That's a treatment for nephrogenic DI. And causes can be either lithium or amphotericin B or hyperglycemia or other diseases, amyloidosis, sickle cell disease, Sjögren's syndrome. They are associated with nephrogenic DI. You can pharmacologically approach it by giving hydrochlorothiazide, because in the proximal tubulus it increases the sodium water uptake and therefore improves the nephrogenic diabetes insipidus, or amiloride also can be used as a treatment. Alright, hyponatremia. SIADH, the syndrome of inappropriate ADH secretions. Due to multiple factors, and the multiple factors, it could be stress, it could be paraneoplastic syndromes, lung diseases, some pharmacology, or just CNS stimulation, all that can cause SIADH. So it's relatively commonly seen in patients with neurological diseases. And due to the antidiuretic hormone action, the kidney is instructed to excessively retain water, and the hyponatremia we're seeing actually is a relative hyponatremia. It's only as secondary to the excessive retention of water. Diagnosis is made by, you have a relatively low urine output, however the patient appears to be hypervolemic. They are on the volume upside. Looking at your urine electrolytes, your urine sodium is higher than your plasma concentration, and your kidney is able to concentrate. Okay, not excessively, but your urine osmolarity is above plasma osmolarity. Treatment for SIADH is also here address the underlying cause, your neurological disease, but overall just fluid restriction. Decrease the water intake. Demeclocycline, because it inhibits the ADH action, or also in development vasopressin receptor inhibitors to treat that condition. Cerebral salt wasting, now different presentation. It is commonly also seen in cerebral disease, but more like brain injury, trauma, cerebral lesions, tumor, or hematoma. And it's not as instantaneous. It appears within the first week of that neurological disease and then disappears within 2 to 4 weeks. This here is now a true loss of sodium. It's not a relative finding of relative hypovolemia. Now here we're really losing sodium and the water goes with it. So the urine concentration triggers the production of large amount of urines. So just from afar, SIADH, low urine production, cerebral salt wasting, high urine production. In cerebral salt wasting, high urine concentration, high urine osmolarity, therefore, not in SIADH. The treatment for cerebral salt wasting is you got to replace the sodium and monitor for excessive and fast sodium shifts. Hydrate this patient because they are volume down, they are dehydrated. And you also can give fluorocortisone, Fluocef, also has been shown to slow down the development of cerebral salt wasting. Intracranial, traumatic brain injury, intracranial hematomas. When would a patient come to the operating room with an intracranial hematoma? We have a normal CT here, and then we look over here, that's diffuse brain edema. I don't really see a hematoma, but that's brain edema, diffuse, all areas, no ventricles, all gone. Look over here, there's this nicely shaped, pushing in, kind of contrast enriched, that's an epidural hematoma, pushing the brain over acute developed midline shift. And then here's the subdural hematoma. Just that sliver here on that side looks a little bit less pressurized. Okay. More like a round, still round shape here present. Still a little bit of a midline shift, but this is a subdural hematoma. Quickly reviewing what's the difference. Epidural hematoma is an arterial bleed, the meningeal arteries, lucid interval, so they had a loss of consciousness, then waking up for a little bit, and then going down fast. Okay, and here time definitely is of essence. Every minute counts. As soon as you take the pressure off, stop the bleeding, this brain will recover pretty nicely, pretty fast. Subdural hematoma, venous bleed, meningeal veins, slowly developing, sometimes over weeks, sometimes not even remembering, I don't know when I hit my head. A lot of patients here are maybe on anticoagulation, and not every subdural hematoma is a surgical indication, could be chronic, acute on chronic. Epidural hematoma never is. How do we grade patients with traumatic brain injury? Glasgow Coma scale has become a very simple, very broadly distributed tool to describe a neurological status. It was developed in 1974 for head injury assessment, and even up to today is part of the major ICU scoring systems as how to grade the neurological status. So here on the side you see the components. It's E, eye opening, M, motor, and then V, verbal. Okay, and then really very quickly kind of like the best status you get from a patient's response. The best marker for prognosis is actually your Glasgow Coma scale at T0, first one, and then 6 hours after, because that really tells you if where a patient is trending up or down. Interpretation, and always here take the best response. Surely there is some interpreter variability, but always give the patient the best benefit of the doubt. Above 13, minor head injury, 8 to 12, moderate, and less than 8, severe. Actually, less than 8 also pretty much gives you an intubation indication, since with a GCS of 8 and lower, there is not really confidence that this patient has protective reflexes. The drawbacks on the Glasgow Coma scale is high intra-rater reliability. You can miss a lot of, especially focal neurological changes, if you only use that. And there's limited experience in peds, obviously. If your patient is too small, what you're asking here for is truly geared towards an adult cooperative patient. So when does a patient come to the operating room for an emergent cranie? Well, we talked about the epidural hematoma, arterial bleed, fast developing, and true emergency, really, time matters. Okay, do not, this is your bleeding patient, do not delay the surgical intervention to fix the problem. Subdural hematoma, here venous bleed, so therefore slower pace in developing, most acute on chronic, slowly worsening over time, and patients on anticoagulation just are here most prone for that because they just don't stop bleeding. Time still matters, but it is not as of an urgency as an epidural hematoma. With a subdural hematoma, there still may need a little time to recover. Then also sometimes we are asked to provide anesthesia in a patient who has diffuse brain edema. It's like the Hail Mary of ICP control. If conservative measures don't grasp and a patient is deemed rescuable, that decompressive craniectomy may look like a doable approach. Decompressive hemicraniectomy. The only way how to control ICP is to convert the rigid cranial vault to a not so rigid cranial vault. After failing of conservative medical management of intracranial hypertension, you make a hole. First you take the bone flap off, and then you decompress the dura. So here in this little graph, you're starting off with an ICP of 30, which is intracranial hypertension. As soon as the bone flap was off, it dropped to 10, and then after dura opening, it's less than 5. When is that indicated? Evidence-based medicine. What data do we have that this is a good idea? Well, the best data we have after stroke. most commonly an MCA stroke. If a patient is less than 60 years old, has functional ability, less than 48 hours after MCA ischemia or cerebral ischemia, then the decompressive craniotomy may improve overall outcome. Transferring those semi-positive findings to TBI, here most patients are younger. Right? However, there is really no good study to this point that the decompressive craniectomy is improving outcome. What we're looking at when you give patients a chance is what the best predictors are for good outcome are when they're young, the GCS above 6, and as early as you perform your decompressive craniectomy, as better it appears to be. But not always if conservative methods would have improved it on its own, or if you had to get to that invasive. All right, last not least, let's talk about spine surgery. Most likely the position, it's prone position. What kind of surgical procedure, what needs they have, and what other factors we need to consider when it comes to spine surgery, meaning blood loss and postoperative analgesia. So spine surgery is performed in prone position. That's how you get access to the spine. Only based on prone position, your interthoracic and your interabdominal pressure increases. So therefore, IVC and the epidural veins are increased. That also promotes increased surgical bleeding. Especially in patients with higher BMI, a prone position also, you have to come up with a plan how to facilitate ventilation and allow diaphragmatic movement. And prone position, there are certain position-related injuries from peripheral nerve injury, but also the possibility of postoperative vision loss need to be discussed with the patient up in front and take every step intraoperatively to minimize the risk. Peripheral nerve injury, obviously, be very meticulous about positioning and padding. For postoperative vision loss, the risk for spine surgery is 0.1%, and it presents mostly within the first 24 hours postoperatively. Risk factors are male gender, obesity, the use of a Wilson frame, and surgical time of more than 6 hours. When you see a patient postoperatively and they complain about a vision change, you should have a differential diagnosis towards the posterior ischemic neuropathy, which is most commonly caused by systemic hypertension. It also can be central retinal artery occlusion or can be cortical blindness. So you will need some more detailed eye exam and data, neurological exam, before you can make that diagnosis, but you should do it as early as possible. If you want to minimize the risk for your patient to suffer postoperative vision loss, you should avoid hypotension, hypovolemia, anemia, and also always monitor your eyes and avoid that there's external pressure on your eyes in that positioning, because obviously that also can create underperfusion. We talked about position. In the previous podcast, we talked about the neuromonitoring needed for spine surgery, most importantly, the evoked potentials and the anesthetic needs, TIVA and neuromuscular blockade avoidance. Don't underestimate the blood loss spine surgery you can have. Complex spine surgery easily can involve an EBL of more than 2 liters due to it's very difficult to control the bleeding of the bone raw surface, and with the increased intra-abdominal pressure, the epidural veins are increased. All that makes it harder for your surgeon to get good control until all the bone is resected, large surface area. What you can do, be preventive. What that means is optimize your ventilation pressure. Okay, make sure you keep your increased intra-abdominal pressure and interthoracic pressure due to positioning as best as you can. Keep the patient normothermic, avoid hypothermia, Hypofibrinolytic agents, TXA, is pretty much standard for the complex spine surgeries. And consider cell saver. Okay, if you expect a higher EBL, more than 500 ml per kilo, more than 3 levels of surgical levels, then a cell saver might allow you to retransfuse and therefore avoid the use of blood component therapy. Last not least, post-operative pain control. Most of patients for spine surgery are at high risk for difficult post-operative pain control due to pre-operative existing analgesia use. They're not opiate naive, and they also have a combination of muscular and neuropathic pain post-operatively. So opiates, yes, that's the main stem of your post-operative analgesic plan, but there should be a plan for additional agents and alternatives, because most likely the patient will need it. Consider anti-inflammatory agents, acetaminophen, Tylenol, NSAIDs. But with NSAIDs, the problem is the bleeding risk and also the not really flush, but out there data about NSAIDs promoting bone non-healing. That's surely not something you want after complex spine surgery. Gabapentin has been shown after spine surgery to decrease the opiate consumption. It addresses the neuropathic pain. Methadone or tramadol, also in the opiate family, but because it does more than just opiate receptor, also may be a better opiate than hydromorphone, hydrocodone, etc. Ketamine as an NMDA antagonist, and also for the multimodal analgesia, also surely something to be considered. And also, be willing to include regional anesthesia, epidural and interthecal opiates, because your surgeon is already right there. He may be able to actually give that over the surgical field, and you also then get the benefits of giving opiates, but in a more specific target. Well, thank you very much for your attention. Okay, that's concludes the talk on the basics for neuroanesthesia, and please feel free to contact me if you have any questions. Thank you.